ما نسمع أي صوت حولك، الصوت واضح جدا.
ممتاز ممتاز perfect. اوكي perfect. شكرا جزيلا. طيب أتوقع okay. Okay, so we're gonna start over with the session of today. Um, I just want to start off with saying that it's an honor and pleasure to be part of this course with you guys. I think I taught 2 or 3 bedsides and examined some of the students. I usually like to start off with some introductory slides about what rheumatology is all about and why it's important. We jumped into the examination part without going over some of the most important parts, which is the clinical science itself. How does some of the disease appear clinically on the skin? And it's very important to go over those signs before we start the examination. But because of the current situation back then, we had to jump to examination. So we're going to cover that part today. At the same time, we're going to go over some of the I just want you to have a feel about what rheumatology is, because it's very important. And just to let you know, from this lecture, it's just for you to comprehend rheumatology, and this is what I want you to do. We're going to cover some of the um, tricks that might show up in the exam, and yeah, that's it for today. I'm gonna send my email to Yazid. So if you guys had any questions, concerns, just feel free to go and send me an email with your questions that's related to the topic or others, anything that I can help with. And I usually reply to my emails every Friday between 1 to 3. So without further ado, I will start. So approach to a patient with rheumatologic complaint. So the objective of this talk is to define rheumatology. We're going to identify rheumatologic diseases. We're going to go over some approach to patient with the rheumatologic complaint. And we're going to describe some of the clinical signs in rheumatology. I like to sum up with some questions. I'm sure that you are more advanced than the questions at the end, but it's just to give you an insight about this disease and diseases of rheumatology, which is, by the way, since I landed on Asir, I've noticed that there are lots and lots of rheumatologic autoimmune diseases that has to be addressed, diagnosed, and managed properly. So, okay. So what is rheumatology? Rheumatology is a collagen vascular disease within several subset exist. So we do have the connective tissue disease that you're aware of, and I'm sure you had lecture about, which is lupus. Rheumatoid arthritis is also considered to be part of this entity. We have seronegative diseases, and I'm going to explain in a second why do we call them seronegative. Spondyloarthropathies like ankylosing spondylitis, and we do have the inflammation of blood vessels, which we call the vasculitides. Don't worry about the slide. Sorry, I'll send it over to Yazid and he will distribute it. As a rheumatologist, we also treat osteoarthritis. We treat crystalline arthropathy, which is very common with gout as well as pseudo gout, and you're going to have it as a lecture at the 6th year as a 6th-year student. And we do treat in collaboration with orthopedic septic arthritis. For me, I prefer to go with this classification because it goes over the non-autoimmune arthritis and the autoimmune arthritis. So the part that covers the non-autoimmune arthritis is either osteoarthritis, crystalline arthropathy, as well as septic. But when we talk about autoimmune, we have the seropositive and seronegative diseases. And under the umbrella of seronegative spondyloarthropathy, we do have ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease associated arthritis. And the reason behind calling them seronegative is because from the beginning of ages, when people started to diagnose, to call autoimmune disease, most of the patient has had to have an IG rheumatoid factor, and rheumatoid factor is an oh my God, I wish that I made one of you guys as an admin. Okay, في مشكلة. Okay, so it's basically, I will try to go to handle and solve this problem. Hopefully it will be solved soon. So the reason why we call them seronegative spondyloarthropathies is rheumatoid factor is usually negative. And when we say rheumatoid, when you talk about auto antibodies in general or antibodies, there has to be our immune complex or antigen antibody complexes. Usually you have an antibody on one hand and you have the antigen on the other hand. But what's unique about the structure of the rheumatoid factor, it's basically, as you can see on the structure on the right, it's an antibody against an antibody. So it's an IgM against the Fc portion of the IgG. And to have this pathological structure inside our body, it carries a significant, oh my God, it doesn't, oh, perfect. Just give me 1 second. Let me admit all people. Yes. So it carries a significant risk when we find it in the serum and most likely indicates a rheumatologic complaint, but it is sensitive, not specific. So when we find rheumatoid factor, it means that the B cell is producing antibodies trying to target specific antigen. And most likely we find it in chronic diseases, in certain infections like chronic infection like tuberculosis, HIV, and others. And we might find rheumatoid factor in certain in rheumatologic diseases other than rheumatoid arthritis, like Sjogren's disease or cryoglobulinemia, and also interestingly in some of the solid malignancies. So it's not specific, but when we find it in the perfect clinical context and setting, we usually call a disease seropositive rheumatoid arthritis, hence the name seronegative spondyloarthropathy, that they are lacking the rheumatoid factor. Type other autoimmune diseases or systemic autoimmune diseases, connective tissue diseases like rheumatoid arthritis, systemic lupus, which will, I think you had it both lectures, Sjogren's, as well as inflammatory myositis. Whoever is interested to read at the summertime, but I don't think that you guys are going to have it as part of the curriculum next year, but you are going to have the vascularities, so the large vessel, medium vessel, small vessel, as well as the ANCA versus non-ANCA associated vasculitis. So this is a very interesting picture, and the reason behind bringing such a diagram or a photo is for you guys to understand that collagen vascular tissue is found everywhere. As you can see, it's everywhere in the system. So whenever you have a patient who is presenting with a systemic autoimmune disease, expect that other organs might be affected as well. And here, I just want to emphasize the importance of going over a proper systematic review whenever you see a patient with systemic autoimmune disease, because you never know which organ is affected and what's next. Okay, so history. History is the most important part of your training. It's the most important part of my training. It's the most important part that will help you reaching a diagnosis in 80 to 90% of the cases. Clinical exam comes next, and then investigation. It increases the pre-test probability to finding a diagnosis. So when we approach a patient like any other complaint, أي مشكلة, أي history, أي station تجي في الexam, make sure that you go over these points, even if you forgot the question for that complaint. ليه? On the list in the OSCE exam, you will find that there is a specific question related to every single part or category of history taking. So make sure that you know them by heart even if you don't know how to analyze the complaint, it will come to you. So when I have a patient who's complaining of a hand pain, let's say, when I take and approach that patient, I will start off with the history. If it's less than 6 weeks problem, then this is most likely an acute problem. But if it's more, then I have to think outside the box. I have to consider chronic inflammatory arthritis, like rheumatoid arthritis. Asking if a patient had a joint pain, whether they have or they don't have a morning stiffness, is extremely important. If you have in one of the scenario that the patient has a morning stiffness of more than half an hour, then you have to consider an inflammatory problem, because most of our diseases, usually lots of cytokines and inflammatory mediator that gets built up overnight and accumulates in the joint. So most of our patients will wake up in the morning with an acute pain or with a morning stiffness. They will complain of a lack of ability to move their joints. And that doesn't apply with a mechanical problem like osteoarthritis. They might have a morning stiffness, but it's usually 5 to 10 minutes, nothing more. If the stiffness is more, then you have to consider other possibilities. The reason behind saying that is usually mechanical problem, from the name mechanical problem, so it gets triggered with the mechanical activity. So when the person starts walking, especially 2 or 3 blocks out of the ordinary, they will start to have pain. But if they have an inflammatory issue, then they will have what we call a post-rest stiffness. So movement is actually good for them. And when they have rest for a long period of time, they will start to complain of pain. And then redness as well as swelling and other associated features that will tell you that this is an inflammatory rheumatologic problem will come in handy. Then you do have the other associated complaints. And I like to ask other questions and related to the diagnosis, differential diagnosis that I think is most likely going on. Like if I think this is rheumatoid arthritis, I'll go on asking about systemic involvement, like lung, heart, kidney. I will also ask about rashes, CNS involvement. If I think this is lupus, I will ask about photosensitivity, Raynaud's, and others. To always tailor your history based on the differential diagnosis that you have in mind, or you can just go with an easier approach, learn all the systemic review questions that you will find in the tables and in any examination book, and just numerate them. Past medical history is extremely important and you have to ask about. And um, the way I like to do it is I like to ask about past medical history first, but at your level, just try to avoid that approach, because people want you to entertain a complaint and then try to come up with a differential diagnosis. The reason why I like to start off with the past medical history is it's actually helped me to find the diagnosis or to the complaint very quickly and more concise and less, and I have more time management over it. If a patient said that they have systemic lupus, been suffering from lupus, like they had the diagnosis 10 years ago and then everything went well, and now they're complaining of severe arthralgias and rashes, then I think that this is most likely a lupus flare and they need to be treated. If a patient said that they have a diabetes and the diabetes is not controlled for the God only know how many years, and now they're presenting with trigger finger, I know that this is most likely a metabolic problem and it's coming from the underlying uncontrolled diabetes. So I need to know what kind of problem they have in the past so I can tailor the current complaint to the past medical history. I hope I'm running with the right speed. Okay. Past surgical history also comes handy because there are some crystal diseases that gets triggered because of the stress of the surgery. The other reason is if a patient had, let's say, an orthopedic, like an osteoarthritis, and they had a knee replacement with a prosthesis, and the same patient came to the emergency department complaining of severe pain and swelling on that knee that had the prosthesis, then I know I will never touch that patient, and that patient has to go to the a surgeon who did the surgery. So it's very important to know that particular piece of information, because if you went ahead and aspirated the knee, you might cause severe infection to that prosthesis. So it's very important to know your past surgical history. Family history also is very important in rheumatologic autoimmune disease. Not to say that autoimmune disease are congenital, because it's not congenital diseases. The fact that one of the parents had rheumatoid arthritis or systemic lupus does increase the risk compared to the normal population, but with the right environmental trigger, they will develop the disease. So we can't say it's an inherited disease, but it plays a major role in the epigenetic rather than genetics. The other thing is like when we ask the patient, a patient who presented with seronegative arthritis, nobody knows why the patient have arthritis, and everyone is asking all kind of questions, and some, if we have a family history of psoriasis, then the likelihood of that patient having psoriatic arthritis is higher. So here comes the inflammatory family history, very important. So we usually ask دايما نسأل باختصار هل في أمراض مناعية في العائلة زي الذئبة الحمراء، زي الروماتويد، زي التهاب الأمعاء، زي التهاب أسفل الظهر. هذه كلها مهمة whenever we're asking questions about family history. With regard to pregnancy history, I'll tell you a true story about a patient who had problems in the past with recurrent miscarriages, and she never told anyone about this issue. The thing is كان في نوع من أنواع العار الاجتماعي إنه هي مش قادرة تحمل, and nobody knew what the problem is. And one medical student did ask her the question, like, have you ever had a miscarriage in the past? And she openly answered that question. In fact, she said she had 3 or 4. She was only 24 years old. And I'm going to teach you that lecture, inshallah, when you're a 6-year medical student. When we sent her serology, she ended up to be positive for antiphospholipid antibodies. And having those antibodies increases the risk for early miscarriages. So what we did is we started her in subcutaneous prophylaxis, low molecular weight heparin, and then she was able to have a normal pregnancy as well as a normal delivery for 3 beautiful daughters. So what I'm trying to say here is pregnancy history is very important, asking all the questions related to pregnancy, delivery, and if they ever had problems like neonatal lupus in the past or others that might increase the risk in the subsequent pregnancy, that we have to take care of when we approach our patients. يعني الأمانة والنية الأساسية هي مساعدة المريض قبل أي شيء آخر. Then we go over drug and allergy history, and drugs are very important in the systemic rheumatologic world, even if they had it once or twice in the past. ليش؟ لأنه lots of medication can contribute to the environmental, what we call epigenetic changes that might develop autoimmune disease. أكيد دكتور منصور مر على موضوع drug-induced lupus, and there is lots of drug-associated or induced lupus. And if you remember from that lecture, he for sure talked about the presence of antihistamine antibodies. So basically what happens is, why do those patients have antihistamine antibodies is because those medication in a patient who have the genetic predisposition to develop a disease, well, due to certain alteration in the amino acid sequencing in the DNA, they might develop disease. And if you remember the amino acid sequence of a DNA, what will happen when we have histone, there will be a histone modification to the amino acid sequence, and that's new to the body. So the body is going to produce antihistone antibodies trying to make a sense of this new amino acid sequence that happened due to the effect of certain medication, certain people. And I'm sure he talked about the medication like hydralazine, prekinamides, and others. And you need to know the concept and always ask questions. Why antihistone? Why SSA, SSB antibodies? You will find a logical answer, and based on that you will know the reason عشان الواحد يفهم أفضل من إنه يحفظ يعني. بالنسبة للألرجي history بالنسبة للألرجي history in medicine and medicine in general and rheumatology, it's very important to know if a patient has had a life-threatening allergic reaction or non-life-threatening. يعني أقصد, was there an IgE mediated reaction or non-IgE mediated? Well, IgE mediated reaction, usually we're talking about anaphylaxis, intubation, and others. If a patient had one of those side effect, then they shouldn't be on this medication whatsoever and should be banned. بس في ناس يقول لك, oh, I had a mild rash, I'm not sure, I had hives, I had some swelling after the injection. And surgical people like to talk specifically about penicillin, cephalosporin. So if someone had a cross reactivity with other medication, it has to be avoided. So whenever you ask about it, so just make sure that you ask about all the drug that was taken and the social status, income. Usually ask also if they have osteoarthritis, if they're living in a building, if they are on the second or third floor, if it's difficult for them to go up and down the stairs, if I can do something with the social service to move them. I also ask about monogamous or polygamous relationships because a number of sexual transmitted diseases are on the rise. And the thing is with the sexual transmitted diseases, it's mostly associated with lots and lots of reactive arthritis, as well as HIV that can present itself and mask itself with so many rheumatologic complaint and presentation like seronegative arthritis as well as psoriasis. So it's very important to ask all these questions. يعني اسألوها بطريقة لطيفة بمعنى انه اسمح لي او اسمحي لي، هذا جزء من التاريخ المرضي، بس انه جدا احنا ما نحكم على احد في الاسئله، بس مهم جدا ان نطرحها وتطرحون هذه الاسئله لانها extremely in rheumatology important. And then smoking مرة مهم طبعا، مو بس في rheumatologic all disease. Smoking is on the rise as well. It's linked to most of the rheumatologic complaint. يعني smoking له link مع rheumatoid arthritis، له link مع ankylosing spondylitis، له link مع other chronic diseases as well as cancer. So you have to ask it. Alcohol as well. Alcohol consumption is very important because we are using medication that targets the liver. So if a patient is using alcohol, we have to talk to them about the importance of quitting it or the minimal alcohol consumption use because of the risk of liver failure. So these are, some people like to add also travel history and blood transfusion over here. So you find your own way and try to get your own approach when you see patients, but don't forget any of these questions because it's extremely important. Like, as far as clinical exam, we went over it with I think I went over it with 3 groups. Hopefully you guys remember: look, feel, range of motion, active versus passive versus resistant movement, fine movement, as well as special tests. Don't forget them. And if you had a station in the exam, knee or hand examination, please, you guys, make sure that you go over all of them. And I've sent some of the links and videos that will help you also to remember all of the special tests that we talked about, whether a Flenkestein test or a carpal tunnel and others. So just make sure that you'll go over this list. طيب. I'm gonna skip this part. طيب. So here is the important part. We talked about certain clinical signs and we start to enumerate them, but I want you to understand how those clinical signs appear. So we talked about squaring of the CMC joint for the group who attended with me. So this is what we mean by squaring, huh? And usually it happens because there is osteophyte, no bone formation at the level of a CMC joint. And if you remember, we said that this osteophyte that usually happen at the first CMC joint is secondary to osteoarthritis because CMC joint is usually involved only in osteoarthritis patients. If you also remember the Bouchard nodes, which is a bony hard nodule of the proximal interphalangeal joint, and the Hebrides nodes that usually affect the distal interphalangeal joint. And this is a classic presentation of what we call nodal osteoarthritis. In rheumatoid arthritis, we talked, if you remember, we said that there is an inflammation at the synovial level that leads to a laxity of the ligaments around it. And we talk about, if you remember, the piano key sign. And this is what happens if a patient had a rupture of the ulnar collateral ligament or laxity due to inflammation. The ulnar head is going to be volarly displaced and it's going to become very prominent. And if you press it, you will get what we call piano key sign. people will also have a prominent knuckles or prominent MCPs, and that's again because of the laxity of the ligament. And they will start to have a radial deviation at the rest level, but they will have ulnar deviation at the MCP joint. And these are some of the changes in rheumatoid arthritis. Alhamdulillah, because of the advances in the medication on biological therapy, we don't see these changes anymore. Here is the Z-shaped deformity, and the reason behind Z-shaped deformity as a thumb, there will be friction at the, remember the thumb only have MCP and interphalangeal joint. Oh my God, no. طيب. Flexion at the MCP level and extension at the interphalangeal joint. And the swan neck is usually extension at the proximal interphalangeal and flexion at the DIP. And the reason behind the prominent heads is what we call a volar subluxation of the MCP. The metacarpal head appears prominent because the proximal phalanges have a subluxed under them. It's a ligamentous problem more than a true joint problem that will cause this deformity. Having said that, you might see a similar changes in a patient with the lupus, but the difference is in lupus patient it is reducible, so ممكن نرجعها, but in rheumatoid arthritis is usually non-reducible, so it doesn't go back in place when you're trying to fix the joint to its normal position. You can skip this one. Okay, so this is important, huh? Whenever you see a patient with lupus and see a face, and this is pathognomonic for a lupus rash. So acute cutaneous lupus is usually, people will have redness in the face, but to distinguish or the difference between lupus rash and other rashes is usually in acute cutaneous lupus, they will have a rash, malar rash, or that spares the nasolabial fold. If you look here, and this is a classic patient with rosacea, the redness extends up to the ridges of the nose, to the nose itself. So usually this part is spared in a patient with lupus, and this is how we differentiate. بس أبغى أعلمكم يعني one of the things why this happened, one of the theories or hypotheses that people are saying, people who have acute cutaneous lupus starts in the skin. فالareas اللي هي protected by a shade of the structure in the face usually is not affected, like this part, this part, this part. But in a patient with rosacea, because it has nothing to do with the photosensitivity itself, the pathology is in the skin itself, then you will see redness everywhere. This is one of the very interesting, I've seen, I think, couple of cases in Saudi and couple of cases abroad. This is what we call a heliotrope eruption or dermatomyositis. Dermatomyositis is a disease affect the muscles, and you will see this violaceous erythema in the upper eyelid. The reason why I brought this image is if you see this, the diagnosis of dermatomyositis is guaranteed. And this is what we call a Gottron papule. And the Gottron papule is usually redness or a heliotrope rash on the proximal dorsal part of the hand, and it usually affects the knuckles. In a patient with lupus ممكن يصير عندهم a similar rash, but it's usually between the knuckles, not the knuckle itself. One of the things that I like to emphasize on whenever you see a patient, examine the patient rheumatologically, because it's a so systemic disease, you have to use the torch, and you have to use the torch on one nostril to look if there is any evidence of light on the other side. ليش؟ لأنه we have lots of diseases that might lead to a nasal septum perforation. طبعا هنا some of the reason, the etiologies of why a nasal septum perforation happen, and you have lots and lots of diseases from infection to drug use, levamisole or heroin drug use, as well as cocaine. But from our standpoint, rheumatoid arthritis can cause nasal septal perforation. Psoriatic arthritis can cause septal problem, as well as granulomatosis with polyangiitis. And why do I emphasize this? If we code those patients early when they have like an early stage disease, we could arrest this disease, and we can treat with the significant immune suppressive therapy, so they will not will have the urge or the need in the future to go and have any nasal reconstructive surgeries. So it's one of the things that you have to detect and you have to examine. As I said earlier, collagen vascular disease can affect every single part. Relapsing polychondritis can cause this problem, granulomatosis with polyangiitis, as well as sarcoidosis. So these are one of the pathognomonic clinical signs that we look for if we think that the patient had a rheumatologic problem. This is a classic plaque psoriasis. This is also a well-demarcated erythematous scaly lesion that you have to look for. The ear, at the hairline, at the scalp itself, at the nail as well. And here is what we call dactylitis. Dactylitis إيش معناها؟ إنه inflammation of the whole digit. كل الأصبع is inflamed, including the proximal as well as the distal interphalangeal joint, with the muscle and the synovium around it. And there are very narrow differential diagnoses when you see such a case. منها أهمها psoriatic arthritis, but there are other diseases as well. Okay, so this is Raynaud, huh? And Raynaud, if I asked you, is a well-demarcated pallor that usually transform to a dusky blue because of the lack of oxygenation, and then upon rewarming, it goes back to normal. It might happen as a normal phenomenon when you're exposed to cold, but the thing is, if there is an underlying endothelial problem, like with other rheumatologic disease, it might lead to this. And this is not fun to see. And to me, this is a rheumatologic emergency. I usually admit the patient, start all the vasodilating agent that I know of, just to try to preserve the fingers from going to necrosis and autoamputation. And one of the tricks that I usually go for to differentiate whether this is a normal phenomenon due to cold exposure or if there is an underlying pathological problem is to look at the nail fold. أجيب الفندoscope وأطالع على nail bed itself. If the capillaries were like this, then I have no problem or nothing to worry about. لكن if the nail capillaries were like في giant lobes, في dropouts, في areas ما فيها أصلا capillaries, then I know that there is an underlying endothelial problem. Okay. So هذه هي الأشياء الأساسية اللي كنت أبغاكم تركزون عليها. We're gonna skip this. And I just want to remind you guys, I don't want you to worry about the exam. انتوا هنا كلكم طلبة، كلنا عندنا نفس ال IQ. I'm sure that all of you are going to do great. وأنا درست بعضكم, I know you're excellent. I just want you to have your own scheme when you approach patients. And remember, كل ال cases are the same. Just try to calm yourself down and approach every patient or every examiner individually. Remember to introduce yourself. Remember to take permission, and don't forget to thank the patient. And if you had any complaint like cough, hand pain, headache, you have to have your own systematic approach. دائما هي تبدأ onset, duration, associated symptoms, systematic review, and always remember to go over all the other questions اللي هي past medical, past surgical and allergy, as well as medication. And the same applies to examination. أعتقد بقينا less than a minute. If you have any questions, concerns, زي ما قلت لكم ارسلوا لي على الإيميل, or feel free to add them to the chat section. And with that, I conclude my lecture. الله يوفقكم إن شاء الله.